been a nurse practitioner for 8 years. And so my initial pull to women started in labor and delivery. This woman feels XYZ. I want to optimize her. I want her to feel her best, get herself back to her normal so that she can be who she was, and not have them feel that they're just in and out in 10 or 15 minutes. Decreased libido, is it a combination of things? Do they need, a testosterone evaluation? Is it due to chronic pain? Get down to the bottom of that. I always just tell my patients, learn what's normal for you, first of all, and then that way you can see where it's deviating.
Today we have Myda Faye on the podcast. She is the newest nurse practitioner at Live Oak, and so I wanted to bring her in and give us some insight on overall women's health and learn about her a little bit so you feel a little bit more comfortable whenever you come in for an appointment with us. Could you tell us about yourself and a little background on you personally and professionally?
Yes, like you said, I'm one of the new nurse practitioners here at Live Oak, so excited to be here. It's been a really good transition for my career. It's been really good things. I'm excited to see where it's going to go. A little bit about my background. So I've been a nurse practitioner for 8 years. I've been a nurse since 2011. So my initial pull to women, my nursing career started in labor and delivery. And so that kind of initiated that passion and interest in women's health, being able to care for those women during one of the most unforgettable days of their life. They're scared, they're excited, there's so many emotions, being able to be that support for them. It was really rewarding as a nurse. And so I knew that when I went back to school and became a family nurse practitioner, that if I could, I wanted to stay in women's health. And so for the last 8 years, I've had that opportunity. I've been a family nurse practitioner in women's health. I've got to work with women from all ages, from young adolescents all the way to postmenopausal and all the things in between. And so, women, we've talked about it before, they're complex individuals. And so it's taught me a lot as a provider, and it's extremely exciting that I get to continue to do that here at Live Oak.
Cool. We're super glad to have you. I have done women's health essentially since I started as a nurse practitioner in the emergency department.
Yeah.
That's a whole different view. I mean, that's stabilization, prevent death. Ours is, everything's rule out ectopic pregnancy. There's, dysfunctional uterine bleeding that we got to make sure you're not going to exsanguinate. And it's the big extremes of that side of women's health. Now I do women's health, but it's hormonal optimization, lifestyle, keeping healthy women healthy.
Yeah.
And you have also done women's health, but what is the difference between, or is there a difference between just your traditional GYN role compared to kind of what you do at Live Oak?
Oh, yeah. I mean, there's a lot of similarities, which is kind of the great thing about getting to continue to do what I love to do. But there is a difference. Traditionally, from my experience, I spent a lot of time. It's a well-woman exam. Some of these women I see once a year and don't ever see them again. If they have a problem, it's an acute problem. We address it. We deal with it. It's not so much some preventative care, but not, and it's like normal versus abnormal is kind of what it is traditionally like. So being able to learn this side of things and be more comprehensive in knowing beyond normal. Now it's, okay, this woman feels XYZ. I want to optimize her. I want her to feel her best, get herself back to her normal so that she can be who she was, and not have them feel that they're just in and out in 10 or 15 minutes, and give them the time. I really like that aspect of it. It's just a different way to offer a woman what she needs.
Nice.
It's been great.
Cool. So I want to just jump into the top 5 questions that the woman is scared to bring up during her normal well woman exam, or just normal women going out through their day-to-day. So I Googled top 5 questions you want to ask your gynecologist. And so we'll just kind of start. Vaginal discharge was one of the top ones. What is normal? When do they need to seek treatment for?
So vaginal discharge is different for a lot of women because what's normal to one might not be normal to the other. I always just tell my patients, learn what's normal for you, first of all, and then that way you can see where it's deviating. Often because women close to ovulation, their discharge is going to change from being thin to thick and mucousy. But if it's changing in color, if it's green, if it's yellow, if it itches, if it burns, if it has a distinct odor that's not normal for them, that's probably time to say something. Because it could be something simple. It could be And bacterial overgrowth, you can fix it with an antibiotic, some overgrowth of yeast, get an antifungal on board. There's a lot of ways to, and some of it's just atrophy as a woman's aging and things are changing. So if they just speak up when something's not their norm, then it's pretty easy to take a look at and usually get treated pretty quickly.
So for the most part, I've seen like the vagina is kind of like a self-cleaning oven.
Oh, yeah.
It kind of takes care of itself. Is there anything that you have to be doing from a maintenance aspect that a woman should be aware of?
So I usually tell women the typicals, like if you go to the gym, don't stay at home in your sweaty gym clothes. If you go swimming, don't stay in your wet swimsuit. You know, you're right. It is a naturally self-cleaning oven. We produce our own natural good bacteria to keep it healthy, and it can overgrow. And if you, after intimacy, make sure that you're using the restroom. Some women who are prone to it, if their partner's not circumcised, sometimes they'll tend to get a little bit more overgrowth. But if they're prone to those and they have recurring, I'll usually tell them, you know, probiotic, cotton underwear is really helpful for that. Good hygiene, just wiping front to back, just kind of the basic stuff.
Okay. A lot of the questions were period related. You know, when does someone need to get their menstrual cycle evaluated?
So that too, you know, like I said, women are so complex. I wish there was this is how it should be, and if it's not, then there's something wrong. You learn your normal there too. A lot of women, average cycle, I mean, a normal cycle for the most part is going to be like 25 to 35 days apart. I'd say anywhere lasting at once 3 to 7 days, but it should be manageable. They should not be soaking pads by the hour. They should not have large quarter-sized to dollar-sized clots. The pain, a lot of women during their cycles just deal with it. Pain should not be excruciating where they're missing work, missing school. So even bleeding in between, intermenstrual bleeding. If your normal is changing, you're having that bleeding in between, you're struggling with, like I said, the changes that it's too much bleeding or too much pain, then that's usually your body's way of trying to tell you something's wrong. It's time to get an evaluation, whether that's get your hormones checked, see your provider, get a pelvic exam, get an ultrasound, whatever we need to do to figure out what's going on.
And with the pain, with the periods, the cramping and everything, is that expected, or is there any red flags that a woman should be aware of that now from the pain standpoint needs evaluation?
Everybody's pain tolerance is a little different. I used to have a lot of patients that some would say it's not painful at all, and then when I'm asking them, you know, they're like, well, I'll miss a couple of days of work, or I'm curled up in bed. I'm like, well, that's pretty painful. So it's learning what you can tolerate and what you shouldn't have any pain to where, like I said, you're missing school and work. It should be manageable. A heating pad, take you some ibuprofen, some Advil, but it should be manageable. If it starts to get, or if it's been that way since they were young, you have a family history of endometriosis, ovarian cyst recurrence, anything like that, then you probably need to be seen because it's probably more.
From the ER standpoint, we had assessment of the bleeding was always kind of tough because I would have some women who I thought were essentially exsanguinating themselves from their description, and then, you know, their blood counts, their indices, everything was normal. And then I've had someone be like, it's just been a little more heavy than normal. And they're like super anemic. We're having to give them blood and everything. You kind of mentioned it briefly, but what is an appropriate amount of bleeding during the bleed phase of the cycle?
So normally during that, like I mentioned, 3 to 7 days, I typically tell patients, you know, a couple of days of heavy is usually within norm, but that heavy is, you should be able to change a regular pad or a regular size tampon every 3 to 4 hours. You should not be changing that every hour. And, you know, when I get into clots, you know, some women are going to see some amount of clotting just naturally as that lining is shedding, but they should be minor. They should not be quarter size falling in the toilet. And I've had women come in and they think that's normal for them. And like you mentioned, then I check labs and they're anemic and they've been living that way. And I mean, it's educating on what is more than what they think is heavy versus that's pretty manageable. Your body's compensating.
And then from a management standpoint, you know, do you change if they are bleeding heavily? Like, how does that manage from your standpoint?
So if they came in and they were initially, I'll usually do some lab work just to kind of see where their numbers are, see what their blood count is, iron levels. If it's borderline, you know, educate on ways to help the cycle, which whether if that's bringing in birth control, bringing in some progesterone, something to kind of help that cycle. then we would do that. But then an iron, daily iron with some vitamin C too, just to manage it, and then just recheck them and see how they're doing and have them monitor that cycle pattern and make sure that it is improving and it's not staying the same or worsening.
Once we just started bringing on the women's health stuff, surprised that almost every menstruating woman that we check is iron deficient.
Oh, yeah.
And that can be a lot of their fatigue, their exercise intolerances because, they're just operating with no iron. And y'all have a bleed every month. Guys just don't exsanguinate themselves every month. And it's not uncommon that we're putting on iron supplementation. And iron bisglycinate, I didn't really know until I got into this space, is much easier in the gut and tolerated better. So we do that with the vitamin C, like you said. And I have a pretty low threshold to do an iron infusion because their ferritins will be single digits, and we see that a lot. And from a supplement standpoint, that's 6 to 8 months of, if not more, of trying to do oral supplementation compared to 1 to 3 iron infusions. It just tanks them up so fast. And so I do like to evaluate for iron and everything. The next questions that were coming up a lot were all related to birth control. What types of birth control are there, and how do you assess for what birth control is best for each woman?
Yeah. So a lot of that's going to be, why do they need it? Do I have a young woman coming in that needs it because she's been having those painful, heavy periods? Is it a woman seeking contraception because they're wanting to avoid pregnancy until they're ready? Some of it's for that premenstrual syndrome, the PMS symptoms that they're experiencing on top of just like the painful periods, the heavy bleeding. So it's their goal in what they're looking for and what they're okay doing and managing on their own versus something that I'm going to manage for them. So there's about 6 things they can choose from. There's combination birth control. So it's got a combination of synthetic estrogen and progestins. And so you're talking like a pill every day. Women often will use that for acne control as well, on top of just like cycle management and contraception. There's a patch or NuvaRing, very similar to that. You're going to get that good period regulation. It just takes away from having to do something every day. So the patch is once a week. The NuvaRing is every 3 weeks. So it takes away from the daily aspect of it, making a mistake accidentally with the daily. But those type of women are the ones that still want their monthly menstrual cycle. They want to have control over that. They want to be able to manage it. When we start getting into the other kinds, it's more of the progestin-only kind. So we're talking Depo-Provera, which is the injection. They'll take about every 12 weeks. They come in for an injection. It's great for heavy bleeding. It does sometimes have a lot of breakthrough spotting. Weight gain is sometimes a side effect to that one. So it's a good option for some, but it does come with some side effects. So just always be honest with the patient so that they know. The other progestins were more long-term, which a lot of patients sometimes are seeking that. They want a long-term birth control, prevent pregnancy. That way they don't have to think about it. The next one on the arm implant, it's good for 3 years. Again, it's a great option. It's not as uncomfortable to get it placed. It's great for someone who wants the contraception long-term. Can also have a little breakthrough bleeding on occasion, so you do have to educate and manage and look out for that. The IUDs, the intrauterine devices, you've got hormonal ones. You've Skyla, Kylena, Mirena. They're great for bleeding control. They're really good for women who have heavy periods. Some of them are good for 5 years. Mirena's good now for 8 years. So really good bleeding control options and that long-term birth control you're looking for. But, with the shot and the arm implants or even the uterine implant, women either won't have a period or there will be irregularity. And so you kind of have to let them know that, because that way they're okay and they're prepared to not have a cycle.
And so from a guy standpoint, I would feel that it would be beneficial to not have a period. But you said a lot of them want to have it still and have it monthly.
Yeah, some of them are convinced that they should be shedding that lining regularly. And so sometimes when you just go and educate, there's nothing to shed when you're on these long-term progestin options because they are keeping that lining thin. Then they kind of understand. But you do have the ones that some of them want a period. They want to make sure they're not pregnant, and they have that like tracking monitor for them. So it just depends on what they're looking for, really.
And so a lot from my aspect, from a hormone optimization in a woman compared to these, I really try to not use these synthetic birth controls anymore. Of course, if we need to, we need to. And if we need to, they're great at what they do. It's crazy. Like progesterone is what we use a lot, and it's confusing for a long time that that's different from these progestins. Mm-hmm. The progestins are synthetic and they are much stronger. So the like micronized progesterone that we use predominantly is not a good birth control.
No.
And so we don't use it as birth control. And so I would say a lot of the ways we're trying to get, again, birth control is great when it's needed. If we don't need it and we're trying to do the more natural and the progesterone instead of everything, then we'll do more of the like natural family planning so that they can track it. That's not being manipulated by these super strong synthetic hormones. Can you give some insight to what that is?
Yeah. So natural family planning, like you mentioned, it's a great option for a woman who wants a non-hormonal contraception method. It does take someone who is going to be comfortable being very persistent in tracking their cycle. You have to have a regular period for it to work because it's based off of cycle dates. So often if you are able to track your dates and know, when your fertile window is, women will listen to the signs of their body as well. So sometimes they're tracking cervical mucus changes, sometimes they're tracking body temperature changes. So if they can get in tune and know those signs, then they can know that fertile window and avoid intimacy during that time. And so it's a great option for someone who doesn't want hormone use and is looking for a more natural contraception approach.
I track about everything these days with like sleep and my heart rate and my steps and yada, yada, yada. Are there any good like apps or devices for women to track to make it easier?
So I've learned this from my patients. The Glow app and the Flow app apparently is very user friendly. So that's kind of like their go-to apps. And, if you're old school and you want to track on a calendar, absolutely. And then put the day you start in and the day you stop in and learn your cycles. So if you have a 28-day cycle from start of day one to start of the next month, then around day 14 is your super fertile window. And so you want to avoid intimacy a couple of days before, day of, a couple of days after to prevent that. Some women are now using even like the new Aura ring, the ring that's tracking that they sleep with, and it's got good data on it and it tracks their cycle and their body temp for them. So.
That is bananas.
Yeah.
So kind of moving in from like, okay, natural family planning to prevent pregnancy, but what about the women who now are wanting to start their family or have another child? What do you look for if someone comes to you like, hey, I want to get pregnant? What does that look like?
So just kind of see where they're at, educate. I always tell women, how have you been trying? Is this just like a new thing we're trying? Have we been trying and been unsuccessful? I always ask people, have you not necessarily been trying, but you just haven't been preventing? Because there's a little difference there. If you're truly trying to get pregnant, then it's important. One, always have the conversation with your provider. What medications are you taking right now? Make sure you're not taking any that are not okay to be on when you're pregnant so that they can kind of make some changes if they need to. But also checking, that's when you start tracking. So again, back to the tracking, put in the day you start, the day you stop on an app, learn that fertile window, and time intercourse this time now. So you want to try to time intercourse around that fertile time. Most women under the age of 35, I'll tell them, give it a year, listen to your body, track, try, be patient. If those that are, after it's been a year, normally it's time to go ahead and let your provider know so they can start doing more fertility testing, whether it's on you and your spouse. Over 35 are women who just have very irregular periods. They're running out of like a window of time there. It's hard for them to track if they don't have a normal cycle. So I'll normally say, after age 35, I wouldn't go past 6 months trying. Go ahead and speak up. Or if you don't have a regular period, we got to get there first before we can have you start tracking. Yeah, it's a good tool to be able to do, but it's also, unfortunately, women can sometimes be on a little bit of a time clock. So listening to your body.
Yeah. From the guy standpoint, sometimes like the guy is the easy part for the most part, but then if you just forget to even be like, oh, this dude goes and hangs out in a sauna an hour every day, or they spend their evenings in a hot tub, or now that it's cooling down, the seat warmers in the truck, our testicles hang outside of our body for temperature regulation. But aside from that, the guys, you can't change much. You know, just make sure, and if they're on testosterone, let like us know so that we can bring in HCG or other meds to do it. But guys, we can't really change much in terms. We can change sperm count, and for the most part, I'm just telling them to do normal, healthy living stuff. Anytime you can reduce antioxidant or improve antioxidants, reduce free radicals, that kind of stuff, they're going to do better if both husband and the partner are happy. It seems to work a little better. In terms of workup, in a guy, I just get a sperm count. In a female, is there much workup? I mean, do you have to check to make sure tubes are open, or what does that look like?
So normally there's hormone testing, timed hormone
Okay.
testing. So they'll get like a day 3 hormone testing baseline, a day 21, see where their progesterone's at. And we kind of use those as a tool to backdate, like when is their actual ovulation window. Maybe they're missing it. Yes, if they've been trying and they can't, often we can do an HSG, which is like a tube dye study where they can go in and make sure the tubes are open and that there's no issues there. I always suggest a semen analysis. A lot of times we get so hyper-focused on the women, and I'm like, let's check the man as well. It's a 2-person effort here. So getting the woman with some labs and an HSG is usually a start while we also run a semen analysis on a man.
When they are in that ovulation window or whatever, are the frequency of sex, is that like every other day? Is that daily during that? Or do you have any insight to when that would be optimized?
Typically, you'll say every other day during that ovulating window. Yeah.
And that does help get a little bit more sperm count in a guy, and so that would maybe help. That's kind of what I've been telling them as well. Yeah. So moving on from there, one of the other things that was brought up pretty commonly was just breast changes. And, from a clinician standpoint as well, I've had women come to me at urgent care, the ER, with breast complaints. And I mean, mine is pretty... I just hope whenever I see the complaint, I'm going in, I'm like, okay, I just hope it's fibrocystic changes, and then I can order a mammogram or something to do it. But what would I need to be what does a woman need to look for? And then as a clinician, what would I need to be looking for an appropriate breast exam and evaluation?
So I always educate women, you got to be your own advocate, especially if you're only going to see your provider once a year for a well woman. A lot can happen in that year. First and foremost, after age 18, women should start doing self-breast exams. They should once or twice a month do a good breast exam, learn what's normal for you. I know that most women don't know what they're looking for at all. I always just tell them, know you're normal. So that way, whatever isn't normal for you, you can speak up and let your provider know. And then it's our job to determine what's benign versus we need to do some more workup for it. Lumps, changes in breast size, skin discolorations on the skin, nipple changes, nipple caving in, bloody nipple discharge in general. Those are usually signs that something isn't right. And so that's when I'll say, let your provider know. We can do some diagnostic imaging and hopefully just reassure you that it was, like you mentioned, some fibrocystic benign finding. But there's more that can be done. If it needs to be worked up further, biopsy needs to be done. Pathology needs to be done. There are other things to look for. And so it's just learn you're normal and speak up when it's not normal so someone can look into it.
The one that I have seen a lot from the ER and urgent care is postpartum breast pain. Mastitis is the majority of it. Whenever they are breastfeeding and worried about mastitis, what does that look like? What do they need to?
So I always tell them it looks like a bee sting, or it's hard, it's red, it's warm, it's painful. Biggest thing is let us know. Keep breastfeeding. You can continue to breastfeed. It's not going to harm your baby. Let us know, and typically antibiotics on board. Okay, knock that out.
And cabbage leaves with breastfeeding mamas, what is that? That's to absorb it?
Yeah,
and
so when
help
they're
them
done. Yeah, we used to have a medication we would prescribe for it, and just too many side effects with it. I mean, even in the hospital, they'll just order a head of cabbage and you start putting it on. Yeah, I tell women, put them a couple in the freezer, get them cold, wear a tight sports bra or like a ace bandage wrap around them, place them in there. They'll soften and get warm throughout the day when you have them on, but that's probably what dries it up the best.
Cool.
Yeah.
So now they're going to kind of move into what we do more here, perimenopause, menopause, sexual health stuff. So I just want to kind of start the perimenopause. I mean, that is one of our hardest things to deal with. What does that look like in a woman, and when do they need to be evaluated for anything?
So perimenopause is that phase before you transition into menopause. And so a lot of people are confused as to what's the magic age, when is this happening, when should I expect to be in that stage of life? It's different for every woman. The majority of them, as early as in your 30s, women's ovaries are going to stop producing what we need, hormonal. And even though you're still making what you need, your levels are decreasing. And so initially in perimenopause, mid-30s to 40s, they'll start to notice their sleep patterns changing. They're having a little more insomnia. They're waking up more through the night. Even those that are still menstruating, they're like, my period's changing. It's either heavier or I'm missing a few months here and there. More PMS symptoms. They're having worsening in their symptoms. Some women will start to have headaches, out of nowhere. They just start happening. They never had them before. They had them when they first started their period and they've been okay. So a lot of it is that initial a hormone shift is happening and your body's trying to tell you. So normally those are kind of the beginning. Women eventually, once they're getting closer, will start to have the more common ones, the hot flashes, the night sweats, irritability, mood swings, unfortunately, joint aches and pains, even skin and hair and nail changes. Women will complain of experiencing that. When true definition of menopause is you go a full 12 months without a period. And so there's not a when is it over? It's more how do we make sure that you can manage your quality of life when you're getting through that perimenopause, menopause phase. For some, it's quick, and others, unfortunately, it's not.
Yeah, and it's like the actual definition of menopause is the 12 months, and then the average is around 51, but then it's like plus or minus 10 years.
Yeah.
Or like 51 average, I would say much less. I don't see much
past
61-year-olds, but it's just such a wider range. It's not like you can say, oh, I'm 49, I'm going to start into menopause. It could happen way early, and we're seeing it earlier and earlier. And a lot of the stuff that I feel like the biggest drivers that women just don't have as much progesterone as much, is like the PMS, the change in their cycle, the sleep, the insomnia. It's like progesterone's our savior for a lot of these. And then now you kind of touched on it briefly, but the menopause, now what does that look like in a woman and what is going on with that?
So menopause is the ovaries have stopped producing the hormones that we naturally need. So their estrogen's down, their progesterone's down, their testosterone's down. They're feeling all the things, like I said, the hot flashes, the night sweats, the mood swings, all of the above, everything. Their libido's down. They don't have that energy level anymore. They don't have that same sex drive that they had before. For some women, like I mentioned, they can get through that just fine. Most need something. Our body, we've had it for so long, and now we don't have it. And so naturally, women don't need to just tolerate it. There's so much that can be done to help them through that phase. Medication, so many things through menopause to kind of help these women out.
And it's so crazy. I mean, 50% of the population will go through menopause. 100% of women will go through menopause if they live long enough.
Yeah.
And the WHI just kind of set everybody, I won't dive into that entire thing, but just when was it, the late 90s, made everybody scared to prescribe these hormones. Yeah. Just to kind of reiterate, they used synthetic conjugated equine estrogen and medroxyprogesterone acetate, which are synthetic hormones that we do not use in our menopause because bioidentical estradiol and micronized progesterone do not carry those same amount of risks. I wish they'd spend another $1 billion to do a repeat study, but
yeah, me too.
What do these hormones do? So just what is estradiol, progesterone, and testosterone in a woman?
So estradiol is their estrogen that they're producing. It is, like you said, it's their bioidentical hormone. It's what their body was making. Estrogen's responsible for most women, body temperature regulation, their bone strength. It's good for mental clarity. It's really good for them. As far as some, like I mentioned, some of them, hair and nails, skin elasticity, collagen, it's really good for those women. Mood, estrogen's really good for managing a female's mood cycles. Progesterone, when you get into progesterone, we mentioned it, it's our happy, calming sleep medication. So progesterone for a woman, it's going to help them get the sleep that they need. It's going to help their cycles be regular and not so heavy. It does also help with mood. It kind of decreases that anxiety for them. Testosterone is, women need testosterone just like men do. We make it too. It helps women with energy. It helps women with libido. It helps them, again, same concept, brain fog, mental clarity. It gives them strength. Women need that. And so altogether, a lot of women, we made it for so long. We relied on it for so long, and now we don't have it. And we're told, that's okay. Just deal with the symptoms.
Yeah. And I feel like that was for a long time, it's like, oh, this is just part of being a woman.
Yeah.
That's kind of what it turned into after the WHI is like, oh, just deal with this for a little bit. Yeah. But then even now we're kind of seeing the repercussions of poor bone health. Yep. I mean, estradiol, testosterone are powerhouses in keeping these women's bones strong. In my career, I never activated the cath lab for a woman that was not in menopause. Doesn't mean it doesn't happen. I'm sure there's outliers there. But just to say, estradiol is very cardiovascular protective.
Yeah.
And on top of the mood and libido, those are things that they can't see, and then joint pain with estradiol. So it's just overall been a disservice to women from that fear that it placed in a lot of us. And so I'm glad that you're here to help and everything, bring everything back. Women have a lot of vaginal atrophy in menopause from the lack of estrogen. What does that mean? And can you tell us a little bit about that? And I'll ask another question after.
Yeah. So vaginal atrophy, as a woman is going through this perimenopause, menopausal phases, and their estrogen is declining. Estrogen is also responsible for protecting the vaginal wall. It keeps those vaginal walls thick. It keeps them able to withstand friction, elasticity. It's just a great protection of the vaginal wall. So naturally, as it declines, what you would expect, those vaginal walls atrophy, they get thin, they get pale, they get dry. And so women can experience that. Often they'll complain of difficulty, pain with intercourse. They'll talk about feeling like they get recurring urinary tract infections. And all in all, it actually has nothing to do with that. It's the vaginal atrophy that's causing that sensation that they're feeling. So a little vaginal estrogen to those vaginal walls solves a lot of that.
Yeah, and that's what I felt. That is something that I failed as a clinician initially. Now that I am in the hormone space more, is that I did see these women at urgent care in the ER for reoccurring urinary tract infections, and I would just treat them with antibiotics. I mean, almost, I can remember a couple of, I feel like I almost saw them every other Sunday or so.
Yeah.
And so it's like, man, and I just wasn't confident enough to do it. And I was like, it's not my place. I don't follow up with them. So I just never did it. Now, I mean, no woman should be denied vaginal estrogen, whether they have cancer, smoker, anything, just because of the impact it makes. And preventing those urinary tract infections can be life-saving if they're an old, frail woman, or it prevents the spread into their kidneys, which is pyelonephritis, and then they can go septic. All could have been fixed from just vaginal estrogen. That's a cheap, benign medication. And vaginal estrogen is pretty cool, is like just to show the collagen and everything promoting of even the vaginal estrogen you can put on the back of your hands, your face, and it helps with wrinkles and everything. Kind of in that same area, what is pelvic floor, urinary leaking? What does that mean in a woman? Like if I know there's pelvic floor therapists out there, what could we use them for to help in a woman that has declining symptoms, and what? So
a lot of times pelvic pain is a big issue for most women. Like a lot of women of all ages deal with a lot of pelvic pain, and it just depends on what's causing that pelvic pain. But often if they're having stress incontinence, urinary incontinence, meaning they cough, they laugh, they sneeze, they accidentally dribble a little, or if they get that urge to go void and they can't prevent themselves from going, it just happens. Pelvic floor therapists are great for that. If they have like a prolapse, if they happen to be having like a prolapse, it helps kind of strengthen that pelvic floor so they can have a little bit more control of that muscle that's supporting the internal female organs. Often if they're having, like I mentioned, endometriosis, is chronic pelvic pain, pelvic floor therapists can kind of help teach them to manipulate and have better control, and the tightening down there and that pelvic floor helps them with that pain as well. So they're really beneficial. They can help a lot for these symptoms that women are experiencing through all stages of life.
Cool. And so a lot of the questions were libido and women's sexual health focus, kind of whenever I was trying to find the best questions. And so I want to kind of get into that because, and another part of just essentially Live Oak is just looking at people's longevity, their health span, how healthy can they be, and I want to kind of throw in even sex span, because if we can keep a couple healthy and happy enough to have sex in their 70s, 80s, 90s, a 90-year-old couple that's having sex is going to be pretty cardiovascular healthy. I want to make it to where it's not a taboo topic for everybody so they can come in and feel like they're not being judged or anything. And I think it's, it's like I wouldn't want to go to my PCP as much and, bring up sexual stuff. I imagine it's even more taboo from a woman aspect. And so a lot of the complaints we get at Live Oak are just, I want my libido to improve. Yeah. What would you look for in that, and how would you go about treating it?
Like you mentioned, sexual health is very important for women. It's good for their physical health. It's good for their mental health, their relationship. Women that I used to have a lot of women that would start the conversation. I'm embarrassed to say this, and then they would bring that up. I'm not wanting to be as intimate as I used to be, or different reasons. And a lot of it is decreased libido comes from that decline in hormone. It can be more than that. It can be mental health. It can be medications that they might be on that's decreasing their libido. But to assess it and find out, have those conversations with them, make sure they feel comfortable talking to us about it. And we can get to the bottom of where is that stemming from? Is it a combination of things? Do they need, a testosterone evaluation? Can we get them on some testosterone supplementation? Is it due to decreased libido, not wanting to because of pain, chronic pain? Get down to the bottom of that. Why are they having pain? Is it, like we mentioned, vaginal atrophy, dryness? Do we need to help there? Libido, back to the mental health. Do we need to educate and enforce maybe some mental health, some, sex therapy, whatever works for them and their partner to kind of get them to that? Some women have a lower libido from like past trauma. So there's just different things that we have to look into and assess with them as to why is your sex drive down? Let's have those conversations and let's help you. Let's get you back to feeling good where you're comfortable wanting to do that.
Yeah, I mean, even in guys, we do testosterone, erectile dysfunction treatments and stuff. And some guys are just chasing libido. Mm-hmm. And it's like testosterone is going to help for sure. But also the healthy lifestyle and that kind of stuff is going to help as well. But then, as you're saying, the mental health is so big into it. Are you much more stressed at work? Mm-hmm. Do you feel like your kids are all over the place? Do you have a place where you could even be intimate without being interrupted by kids? And then relationship status. There's just so many other psychological aspects of libido that, I do try and dig in with the guys as well. And I think women are even more sensitive to that as well. So I think that was crucial to bring that part up. We do have some options that we can offer women in terms of sexual health, in terms of sex drive, sensitivity, lubrication. What are some options that you've used in the past that have helped?
So lubricant, like you mentioned, lubrication is really good to kind of help women. It helps with arousal, and it also helps them with comfort. It protects those vaginal walls. So lubricant's really good for them. Discomfort during intimacy. I mean, if they want to try the pelvic floor therapy, that sometimes helps as well. The vaginal estrogen will help as well. Testosterone, like we mentioned, will help as well. There's even, one of our newer, it's not newer, but newer to us, the O-shot that we're starting to offer. It's a technique that we can go in and kind of replace that platelet-rich plasma from a person's own body and inject it down there, and it helps the female. It helps them to get more lubrication. It helps those walls just feel better, more elasticity, collagen, and it just helps with the urinary leaking as well. So there's a lot of good options out there right now for that.
I've used PT141 or bremanolitide or the brand name Vyleesi as kind of like the female Viagra, and I've had good success. Some women don't tolerate it very well because it can cause headaches, flushing, nausea. And I've tried a couple routes with them, like take it a couple hours prior, which is not always the most fun to try and time and then deal with the headache and nausea and then try and
be intimate.
And then be intimate after that. But some, it does amazing for. The backstory is kind of it's bremelanotide is the generic of it. And that comes from the peptide melanotan, which is a peptide people were injecting to make themselves tan, but it was also improving libido in a lot of them. And so they isolated that little spot. And then now we have a even FDA approved bremanolitide, Vyleesi deal. So that is just kind of neat little backstory. Yeah. Addie is another one. Vyleesi or bremanolitide is like a on-demand, kind of like a female Viagra. Vyleesi is supposed to help just in the background improve. Have you had much success?
Yes and no, kind of like you mentioned, more so cost and then side effects for some people. So I would say I did more Addie. I prescribed more of the Addie, the flambanserin. It's that pill, you take every single day, and it's supposed to help more on like the brain. It increases dopamine, norepinephrine, and it kind of drives that behind for a female, like their desire points. So that one I had in women success with it. They did see more improvements with that one.
Something, since I've been dealing with the guy aspect a lot more, is from the ejaculation standpoint. There's premature ejaculation and delayed orgasmia or ejaculation. And, I have some techniques to kind of help with those guys, meds and that kind of stuff. But one of the things that I came across that was interesting, that is, again, unfair to women, is that the average time to ejaculate in a guy is like 5 minutes and 10 seconds. The average time to orgasm in a woman is like 14 to 16 minutes. Do you have anything that seems to be working well to help women achieve either orgasm easier or sooner, to help from a woman's standpoint bridge that gap?
So there's some like medications, we have a topical medication called Scream Cream that helps women. They apply it to that vaginal clitoral area within about an hour, and it helps. A lot of women have had really great feedback with that. It kind of helps with that arousal. Lubrication always helps for women. One of the things I heard of and watched recently, kind of made a good point. Women, if they will just get creative, read a good book that will stimulate that arousal before you're going to be intimate, it just kind of helps bring that forefront for a female. And so that way they're ready with their partner, and they can hopefully be more in tune at the same time. And so then they don't have that big time gap for them.
Yeah, and that's something I try and tell with the guys. It is hard to bring up in a sensitive way, for both guys and girls, I'm sure. But if a guy is struggling with like premature ejaculation, I'm going to give some meds. We have some options to help them. But then it's like, be mindful of your partner, communicate so that the partner can be aware. But then also, like you said, maybe they get a running start prior to starting, so that there isn't much of a gap and that both partners are satisfied at the end of it. And I think really that's all the stuff I wanted to talk about from a sexual health aspect. Is there anything else that you thought of that we haven't?
Touched a lot of it, yeah.
Just rapid fire, quick questions. You don't have to go into great detail, but just a women's health myth that needs to die.
That as we get older, we just should tolerate what's going on.
Okay.
That's not true.
Yeah. We have ways to make it, gracefully age along the way. One sign of hormone imbalance every woman should know.
Their period's changing.
Okay. Yeah.
That's their body's internal alarm system letting them know, like, something's changing. Your period's going.
Got it. One piece of sexual health advice you wish every woman would know.
Lubricant. You don't have to necessarily need it from a vaginal dryness. Lubricant's your friend. It's going to help. It helps everything. It helps protect the vaginal wall. It helps with arousal. It helps just with intimacy in general.
And that was surprising to me. I was listening to something and she had said, use lubricant as you would sunscreen. And, from a dermatology standpoint, we should wear sunscreen every day to prevent aging, skin health, everything. Mineral-based, you don't have to put chemicals on yourself, but mineral-based, and same kind of with the lubricant is like, it's basically like sunscreen. Yeah. Use it every time. It's going to prevent microabrasions and just all the benefits you just said. So that was kind of surprising to me as well. And then is there anything else women should track aside from their period?
Their sleep. That's one of those early signs that something's changing. If you're starting to wake up a lot in the middle of the night, you weren't doing it before, your body's trying to tell you something's changing.
Two kind of questions. Where do you see the Live Oak, just women's health, going from here? And two, could you just give us what it looks like to come in for a well woman exam at Live Oak? Yeah.
So I think we're doing really big things with the women's Live Oak side of things. It's great to kind of tie in with the men's. It's like a one-stop shop for women now. You can come in, you can get your yearly exam, you can get your hormones optimized, you can get weight loss, you can even get all the aesthetics things. We've got a great team over there. So it's amazing. I think it's going to come. We've got a lot to offer coming. And then as far as normal appointment to expect when you come in for your well woman exam, I will have a conversation before anything. So kind of just touch base in general, like, how are you doing? Anything you want to go over, any problems? And then conversation, we're good, then you'll change, and then we'll do a head-to-toe exam. So it does involve from the listening to your heart and lungs to checking your thyroid, palpating your thyroid, breast exam, abdominal palpating, and then, of course, the vaginal exam. If a pap smear is due with the cervical cancer screening, that is every 3 to 5 years with HPV screening. There's a lot of depending on age and history. But if it's due, then a pap smear will be done as well. And then if there's anything abnormal, then we'll have a discussion in regards to that after.
Cool. And that can be, we try and separate that. And then if hormones come up, then we'll try and do we'll draw labs and then even, an hour-long hormone follow-up to discuss them as well. You've done really good bringing in, now we offer a lot of these more well woman exams and just even dealing with normal vaginal complaints and stuff or breast complaints that we weren't doing from a hormonal aspect. And you've done really good with that. So I'm super pumped for you to be here and how you're reshaping that. Y'all have made another Facebook or social media branch of Live Oak.
We have.
And do you know those handles offhand?
Live Oak Women's Wellness is for both the Instagram and Facebook.
Okay, cool. Yeah. Did y'all make a TikTok?
We were talking about it the other day, but we have not made one yet.
Okay.
Yeah.
Because I remember she asked, and anyways, I hadn't seen it yet.
Yeah,
it's bad if I haven't seen it on my end, but
we have some videos. Ready for you.
Good. And so that was the deal. If they have to come onto the podcast, and I have to make videos with them.
Yes. Those are coming.
Yes.
Y'all be ready.
If you want this kind of thoughtful, individualized hormone care, that's exactly what we do at Live Oak Testosterone. We offer telehealth across Texas. Thanks for watching. Hit like and subscribe. Drop any questions below, and we'll happy to bring you more no BS hormone education.